Good afternoon again. When I received the invitation for this meeting and I saw the program and that I have to debate with my friend Hassan from Mansoura, then I had my heebie-jeebies that how I'm going to do it. This is just like facing Mike Tyson of open radical cystectomy. But nonetheless, I will try to answer all your critique, which is, of course, you have a point, and I will see whether I can convince you that that is not the right way to go forward. So we have two weapons. You have a knife and I have a robot, so my robot is bigger, so hopefully I can win the argument. No question, the radical cystectomy is the most challenging and morbid operation we do in surgical uro-oncology. Because it has three components: cystectomy, pelvic lymphadenectomy, and urinary diversion. And we have three approaches: open, laparoscopic, and robotic. Now, coming to the open radical cystectomy, I know you have been practicing this for many, many years, and it has been around for over 130 years, but its morbidity remains very high, 5% major and 60% minor complications. And these complications are due to the fact that we lose a lot of blood. You may not be losing that much, but many other people lose a lot of blood. Pain as a consequence of traction, ileus, and wound complications which are not insignificant. So you may say that the surgeon finishes quite quickly, finishes the operation in 3.5 hours, but the patient is in the hospital bed screaming in pain for many more days. So we have increasingly challenging cystectomies knocking at our doors, patients who are very obese, patients who had previous radiotherapy, and patients who need palliative procedures. And I can assure you that if you see one of these patients being done robotically, you will be convinced the best way forward for these procedures is to be done robotically. There is about 2.5 billion people around the world who are obese, and this varies in degree. And it is sad to say, I know the fact, that the most morbid population in the world lives in Kuwait. So for Kuwait, I think it's a high time we start a robotic cystectomy program, because this is the best tool to operate on these patients. This is a patient who traveled from Scotland, Aberdeen, to have robotic cystectomy in guys. They do have a robot, but they don't have enough experience. His BMI is 50. And this is day one after a robotic cystectomy, and on the left side, day 7, when he's about to go home. Had I done an open operation on him like this, then I can assure you he wouldn't have recovered that fast and gone home. What about alternatives to open radical cystectomy? We must embrace any alternative approaches which offer reduction in morbidity, but without compromising oncological outcomes. I re-emphasize, without compromising oncological outcomes in the best interest of our patients. Standard laparoscopy is well established, is affordable, it is available, it's a proven efficacy, but about 90% of the surgeons suffer from occupational injuries, and people like Inderbir Gill, who even were very antagonistic to robotics, has given up laparoscopy and doing robotics. Laparoscopic cystectomy is technically highly challenging. Therefore, the only realistic alternative would be a robot-assisted radical cystectomy. The main criticism of robotics is the cost. It is a tool in urology which is the most expensive tool, and as you rightly pointed out, the factors which are driving it, the company itself, the hospital, it is just like a W for an individual house. The surgeons are very keen to get onto robotics, and the patients, because they read in the media, they go on internet. But the society demands evidence that this is justifiable or not. So what is the evidence? There is a tsunami of evidence as far as the robotic radical cystectomy is concerned. There have been 4 randomized controlled trials, 3 comparing open and robotic, and 1 trial which I conducted in guys, open, laparoscopic, and robotic. What these trials, the endpoints were lymph node yield and complication rates. I think they were not the right endpoints but to assess this technology. What the key findings were that there is lower blood loss, lower wound complications, shorter length of stay, and equivalent oncological outcomes. Even in the latest trial, which is published in the Lancet, you can see that the blood loss was less in robotic, the transfusion rate was lower, the hospital stay was equivalent, although this is USA, not other countries. Operating time was slightly longer, and the margin rates were equal. But what is the criticism of these trials? They did not use the intracorporeal approach, no adherence to the ERP pathway, and the diversions were mostly ileal chondri and extracorporeal. So therefore, in UK, there is a trial running at the moment. In fact, we have recruited about 270 patients comparing intracorporeal versus open radical cystectomy. What is the national data say? So you can say in a randomized trial, they are high volume centers and they are experienced surgeons, and therefore the results may be better. But nationally, if you look at the 29% transfusion rates in open, 12 days of length of stay, 6% wound complications, equivalent oncological outcomes. So therefore, there is no question that in transfusions, length of stay, wound complications, robotic cystectomy does better than open counterpart. We have been doing this for last 15 years, not seen a single port site recurrence, not peritoneal metastasis. You have to be very meticulous when you are doing the cystectomy and putting the specimens in the bag. You must not allow any spillage. What we have learned over the last 15 years is robotic cystectomy means less blood loss, shorter scars, shorter length of stay, and less or equal complications. Operating time, if you are training someone, for example, we have fellows regularly, they take longer, the cost is higher, and oncological outcomes are the same. We have even up to 10-year oncological data, no difference between open and robotic. So if you look at this table, then you can see that there are many parameters which I have compared: incisions, blood loss, analgesia required, bowel function, hospital stay, post-op recovery, wound complications. Robotic definitely does better. Did we have the realistic expectations from this technology? That is the main question. I think what we expected, because we are spending so much money, there will be so much difference between open and robotic. But actually, the difference is not that vast. The difference is incisions, infections, and transfusions. This is the main difference. As it any minimally invasive surgery, whether you take a nephrectomy, whether you take partial nephrectomy, donor nephrectomy, renal transplant, robotic renal transplant, radical prostatectomy, and lastly, radical cystectomy and orthotopic bladder reconstruction. So these are the 2 patients exactly having the same procedure. The difference is about the incision. And if you have an audience and a relative, God forbid, or a friend who needs this operation, if you have an experienced surgeon, robotic surgeon, who you will send your patient to someone who is going to do the same operation through a long cut or through a small cut so that he can go home early. So at the end of the day, what I mean to say to you all, the technology is shaping the society, and society is shaping the technology. Robotic cystectomy is evolving, has come a long way. but open cystectomy has come to a dead end. As far as the robotic is concerned, still it is maturing, and hopefully it will get better and better. But I don't think there is any hope for open cystectomy to get any better. Therefore, ignorance is not an option. We should adopt these technologies, but sensibly. As my colleague said, that we must be very meticulous in our data collection, data reporting, training, high volume centers. But the main criticism of this in front of cystectomy is the cost. If the cost becomes equivalent to laparoscopic or open, I can honestly tell you, people will start asking you, why not robotic rather than why robotic? There is no question the more competitors will come into the market, and the prices of these machines will be driven down. Intuitive Surgical has actually done the biggest injustice to this technology because of the cost. Should we be using robots for radical cystectomy? Definitely yes. But obviously in high volume center, people who are skilled, they do large volume of cases. And that applies to even open cystectomy. The open cystectomy in Mansoura cannot be the same as open cystectomy in some small town in other parts of the world, because the people are doing 2 or 4 cases rather than 1 case every day. There will be difference in your competence level, in your outcome levels. By the end of the day, cystectomy outcomes dependent on the patient, the disease, and the surgeon's expertise. My feeling is that bladder cancer has a lot of catching up to do. We are far behind the rest of the cancers, and it needs a multidisciplinary approach for its management. And that multidisciplinary is not about the surgeon, it is the whole team, the surgical team, the nursing team, the oncologist, the radiation oncologist, radiologist, and all the team together. So this is our team. I'm very grateful to all of them that we run a multidisciplinary service where all these people contribute. My final thoughts about robotic cystectomy, the difference is not as much as we thought initially, will be based on the cost. Robot is just another tool, and the surgeon is still the most important factor. So my advice to you, if you have a patient who needs this operation, you don't choose the tool, choose the surgeon. If your surgeon is good, he will do a good job, irrespective whether it's knife or the robot. Robot-assisted cystectomy will become the standard of care. No two things about it. In our center, 80 to 90% of cystectomies are robotic. There will definitely be a place for open radical cystectomy. So, Dr. Hassan, we will still need you for those 20% of the patients, because they are highly challenging cases who are coming to open cystectomy now in various centers. But the future is towards minimally invasive. There is no two words about it. I think that is how we are heading. And if you are ignoring that fact, then actually that is not the realistic approach to our management of these patients. Thank you very much.